Welcome, everybody. We're gonna wait a few minutes just so that way everybody can log on. If you are logging on and you can hear me, please let us know who is here and what hospital you are from or what facility you're from and how long you've been a navigator. We always like to know who's in the room and how much experience is here, because together it's a lot of experience. So we're just going to wait a few more minutes. Thanks for joining us today. We have action-packed presentation, so we'll get started in just a few minutes here.
Sherry,
Yes.
the chat is disabled, at least on mine.
Oh, thank you for letting us know.
Uh-huh.
We will fix that.
It's fixed now.
Awesome. Thank you for letting us know. Yes, and please ask questions or to let us know. Thank you. All right, guys. Few more minutes. Please sign in. Let us know where you're from, your site, and how long you've been in your role. And thank you, Rebecca. All right. Getting started. There's a few more people signing on. Oh, here we go. St. Francis, welcome, Andrea. Shop Coronado in San Diego, Tahoe Forest. I love this, really great. I'm awesome representation of California statewide. We have O'Connor Hospital since 2021. I love that. So you've got some experience. Emerson from Long Beach is in the house. Hey, Emerson. Lake Charles Memorial, Louisiana. We'd love to have our national organizations. We do some national work. So once in a while we have some out-of-state collaboration going on. So it's great. I love this. Very excited to have you here. We have Salinas Valley Memorial. That's a new site. Really excited. And of course, our mentor, Wendy. Shout out to Wendy and Loma Linda. Well, welcome everybody. We're going to get started and please continue. We love to see who's here, and that way you can network and see if there's a navigator in your county. So please continue to let us know that you're here. We're really excited. Definitely. I see some stats. Somebody was born in Arrowhead, so I love that. Love the chats that are going on. All right, so we're going to get started now. And just to let you know, we have nothing to disclose, and all of our presentations are available through Creative Commons for attribution, which means we give out our information for free. You can't change it, but if you want a copy of the slide deck, we do send that out in a follow-up. Okay, next slide. Our objectives for those who want CEUs, we are going to identify strategies for navigating patients with dual diagnosis, verbalize resources for patients in mental crisis, and identify factors and warning signs for patients experiencing suicidal ideation. And you will receive a post-event follow-up with the evaluation as well as other materials from today. So our agenda is we're going to welcome everybody, and I think we're already doing that, some California Bridge announcements, and we're going to go through behavioral health, navigating patients with dual diagnosis, understanding suicide, and also talk about legally detained patients, our famous 1799 and 5150 holds. And then what I like to call the meat and potatoes of if you are not a vegan, right? But the main part of this presentation is our case studies. We have some real life case studies from some of our bridge partners, and we are really excited that they're going to share these complex patient case studies really to help. So really, if you have a question, make sure that you ask, because we have some experience in the house with our social workers. So we're really excited to present this. So let's get started. All right. Welcome, and we just want to make sure for the best experience today, we don't want you to cut out, so make sure you have your computer and a power outlet. I'm doing that today. My computer hasn't been on, has been on the brink, but we're good. And so close unnecessary windows if you're having a problem with the streaming. Use chat and make sure, and it looks like everybody's doing a great job today, because I see everybody, it's addressed to everyone, because if you only put it to me, then nobody else can see the questions or what you're saying. So make sure that your chat is to everyone. Closed captions are available if you need that. And anything for any security issues, if anything happens, we will immediately end. Okay. All right. Just some housekeeping. So we have some California Bridge announcements, and I just really quickly wanted to go over, next slide, our Bridge Navigator program. If you have not met the deadline to apply for the grant, we want to make sure that you're notified, or your facility. Some of you are processing the grant in conjunction with your team at your hospital, but our final deadline has been changed. We have two upcoming deadlines: September 30th for the round that we're on right now, and for our last and final round, December 15th. And actually it's of December 2022, not 2023, not next year. So December 15th of this year is the last round for funding. So just want to make that point that out to you guys. So if your hospital has not applied, December 15th is the last day. So please let your facility or whoever is handling your grant to know. No, we will no longer accept applications for the Bridge Navigator program. Next slide. And then for our bridge grantees and our BHPP navigators, we have a in-person building and strengthening your bridge navigator program live in person in Los Angeles, November 1st. We will put the registration in the chat. And again, this is for all BHPP and BMP navigators, and we will be in Los Angeles. So we hope to see you there. All the information is in the chat and on the registration site if you have any questions. So really excited, looking forward to seeing you in Los Angeles on November 1st. And we're really going to tailor make it to everybody. So invite your champions, invite your supervisors, please. Everybody is invited. All right, next slide. If I always like to give a review of our California Bridge goal, and that's 24/7 access to high quality treatment of substance use disorders in all California hospitals by 2025. Huge goal, 330. We are at approximately around 240 applicants that have either been funded and approved or in the application process. So we are well on our way of our goal to 330 hospitals. So we're excited. What is the California Bridge model? I always like to review very quickly. We are revolutionizing the system of care. Our three pillars, and I love this slide: low barrier treatment. That's our docs giving our buprenorphine when patients say they're in opioid withdrawal without a urine tox screen, without staying there for hours. They state they're in withdrawal, that's confirmed, and they get their boop and their prescription, and they're out, hopefully fast-tracked in an hour or two. That's the low barrier treatment. The next two pillars are what we do as navigators. We connect to care and the community, and that's what you specifically are doing. And we really appreciate all your hard work. We know that it's hard getting referrals. We've heard the struggles. It is easing up after COVID with more beds and more inpatient available. And then the last is culture of harm reduction. And we really want to just make sure that you guys know, and it's okay if you don't have naloxone on board yet. Harm reduction is reducing stigma as well. So if you're doing reducing stigma training for your staff, we know it's a very hard road and we are here to help. So these are our 3 pillars. This is what our foundation is for our success in our California Bridge model. Next slide. So we're going to start with behavioral health. We're going to start with a poll. Can you go back one? We have our poll. I don't know if Aiden can put that up. We want to know, before we begin, do you assist patients with opioid use disorder only, all SUD patients, all SUD, and dual diagnosis? We want to know who you're getting referred to in the emergency room. And we just want to know who's in the room, get the feeling, and it's okay. There's no right answers, you guys. These are just, we want to know. We don't know every facility and what you guys are doing. I know there's a lot of navigators that see all SUD patients. I've heard that a lot. I've heard, that all SUD and dual diagnosis. And then we have some new facility and new sites that are just starting with opioid use disorder. And again, that's where we all started, right? If we can remember way back when we started this venture many years ago, that was what our original starting, and then we've advanced through then. Okay, so we're just gonna wait till everybody answers. And then it's gonna show us. Should show us the answer. All right, so it looks like all SUD and dual diagnosis, 71%. That is wonderful. So 10%, and that might be our new sites. So you're going to learn a lot here. And then 22 are still seeing SUD patients only. So again, we have a wider range. And so this is going to perfectly tie in no matter where you're at. I like it. All right, next slide. So we're going to start by talking about America's mental health crisis. And if you have not been aware, this slide comes from 988. They changed the national crisis hotline, warm line, which was a 1-800 to the 988 number. We also put the toolkit in the chat. So this slide, we're not going to take attribution for it. This is directly from SAMHSA, but they have not only a slide deck that you can train your staff and people in general about their line 988, but they have posters, cards. They have everything you can need for this campaign. They want to spread the word about their new 988 number. You do not have to dial more than 3 numbers. So this is a slide directly from them, from SAMHSA. In 2020, there was approximately 1 death by suicide every 11 minutes. In 2020, for people aged 10 to 14 and 25 to 34-year-olds, suicide was the 2nd leading cause of death. And then from April 2020 to 2021, over 100,000 people died from drug overdoses. And for many of you guys, we saw on Slack that your overdose awareness day, was really bringing that subject to light. So we really appreciate that's where we're at right now with the mental health crisis. Next slide. So what is behavioral health? Well, it includes the emotions, behaviors that affect your overall well-being. Behavioral health typically refers to both mental health and substance use disorders. For some of you that attended last year, we had our social workers and LMFTs. We went over the basics of behavioral health. And with that, we developed a curriculum that will be attached to the new Sun Toolkit. So really shouts out to our comms team. They will be reprinting our new Sun Toolkit with this additional behavioral health section. So come October, you're going to get this information. So I'm going to kind of go over it kind of fast because you'll have your hands-on your own new Sun Toolkit with this chapter. Our old toolkit is still great, but this one will have the new behavioral health section. So again, that's where I'm taking all this information from. We developed it with our social workers, and so we're really excited. So if I'm going kind of fast, because like I said, the main meat of this topic is the case studies. So next slide. What is dual diagnosis and co-occurring disorder? Well, it's a broad category for somebody experiencing two illnesses. It's typically used dual diagnosis when it's mental health and substance use. It also can be used as co-occurring disorder. And so we just want to make sure that you're familiar with these terms and that you know, especially when you are when you're navigating, because this is one question you want to ask. Do you take care of only substance use disorder patients, or do you do dual diagnosis? Very important question when you are vetting or screening facilities to send your patients to. So definitely we would love for you to be versed and know the difference. And about a third of people experiencing mental health disorder and about a half of people living with severe mental illnesses experience substance use disorder. So really these are very prevalent with the patients that we serve. Okay, next slide. What is a mental health disorder? Well, it's more common. 1 in 5 adults live with mental illness. This was taken from 2019, prior to COVID. So not sure if this has changed or not, but we just wanted to make sure that this is very common, and no matter what setting you guys are in. 1 in 5 is a lot. So that means maybe somebody in your household, if you're 1 in 5, right? Doesn't mean that it's a crisis or they're, suicidal. It just means they are living with it. So, hopefully this will bring to light and reduce some of that stigma. Next slide. What are some common? And you guys can type some in the chat. You know what mental illnesses that you're seeing or diagnosis is. Here's some of the most common: anxiety, psychotic disorder, mood disorder, bipolar and depressive, conduct disorder, post-traumatic stress disorder, and attention deficit hyperactivity disorder. So those are the most common. And I love people are already putting in the chat, what are you guys seeing the most of? And depression and anxiety are the most common in our ED. Yep, almost 99%. Childhood trauma, yes, that's definitely been the adverse childhood experiences and trauma, definitely. Anything else, you guys? PTSD, I love this. You guys, you're the experts here. Yeah, anxiety, a bit of schizophrenia. Yeah, definitely. Okay, we just want you to note SUD, particularly stimulant use, may look like a mental health disorder, but usually goes away after cessation of use. So I'm sure that you guys have seen this, right? Once a patient stops using stimulants, methamphetamine, their mental health disorders such as hallucinations or psychotic episodes would go away. So really, we just wanted that to note. So definitely people, yeah, anxiety and depression look definitely like the #1 in our EDs. So thank you very much. Yeah, that's great. Okay, next slide. I like, when I was doing this PowerPoint presentation, I was looking at, are they similar? Well, mental health disorder, the severity can range from no impairment, mild, moderate, or severe, right? It's not always a crisis. It could be stigmatizing, and there's a loss of hope. Substance use disorder, on the hand, is integrated with behavioral health. It's a specialty, and sometimes it's misdiagnosed or underdiagnosed. I know you guys see this a lot, right? It's not diagnosed. They are very similar. And one that really comes to mind is the stigma. Both of these have lots of stigma around it. Some patients will deny both. So very, very interesting on establishing that trusting relationship. So definitely they are points of similarity. So what do these patients look like? Next slide. Just want to make sure. What's their presentation when they come in the emergency department? A lot of you have already nailed this, right? You've already given me the answer. They're depressed, they're anxious, they're confused, right? A lot of times they're hallucinating, argumentative, refusing treatment. How many times have you guys seen patients refusing treatment? Um, they're not being truthful. And, most of the time it's the stigma. I'm seeing that they're also guarded. Yes, very guarded. They don't trust healthcare. They've, been in circumstance that it was not the best. So definitely rapid speech. Yeah. Guarded, angry. A lot of times comes out angry, right? They're not really wanting to do anything. They're refusing. I think that's kind of a big red flag is when patients start refusing. Normally there's a reason behind their declining, right? Not refusing, they're declining services. So definitely that's a red flag. And one of the notes here is not all patients with behavioral health issues are in crisis or violent. Most of our navigators, I know you guys have great experience with just de-escalating the patient. We have some great navigators that give us, or they're going to give us their case studies, but it's getting that trusting, building that trusting relationship, right? So no matter how they present, you as a navigator really need to know your de-escalation and just how to build that trusting relationship. Um, no one ever helps. I like Destiny. I've already heard all this all before. No one ever helps. I just want to leave. And that comes from hope, right? No hope. That's Emerson said that before. They are so not hopeful because the last time somebody misdiagnosed them, or they just didn't receive the treatment that they thought that they would when they came to the hospital, right? Or how right now, I know my emergency room, there's a 2-3 hour wait. And that's kind of on a good day right now. So I know some of these EDs down here in Southern California, we are slammed right now. So I know sometimes, they may wait so much time in the ER with no hope and really feeling like nobody's taking care of them. So again, this is what the patients present from. Next slide. Okay, supporting patients with dual diagnosis. Really want to make sure that that navigating the behavioral workflow. What's really important is the roles of the healthcare team. Know what their scope is, know what they're doing as part of the healthcare team. Does your social worker see patients first and then you are consulted from them? Does your nurse reach out to you directly? Do you know when to get social services involved? Really know the roles and the workflow. Okay. If you do not know these two first, it doesn't matter with the rest of it, you aren't going to be in a collaborative environment for your patient. So, some people have built those relationships. This is all about building relationships and where your services can come in. Sometimes it's in the beginning, sometimes it may be in the middle, and sometimes it may be at the end when patient may be feeling better and is not in a crisis situation, or maybe a hold is lifted. LaToya is going to go into some legal holds, but maybe they've discharge that patient and de-seed the hold, and what else is left to do. So know your role and always work with them. If you don't know their role, and they don't know yours, it will be a very bumpy ride. So always establish that. Definitely ask, hey, when's a good time for me to discuss substance use? When's a good time for me to talk with them? And it might be initially, right? It just depends on your workflow. So please always check with them. Always collaborate with the social services team. You are not alone, and they have the experience and the skills. So please reach out to them. Specifically when there's anything ethical involved or any type of harm, you really want to make sure you let your social services team, they can be the difference between letting that patient leave or getting the care that they need. Making sure there's a referral process for patients with dual diagnosis. That's really working with the healthcare team. Like I said, are you going to be consulted in the beginning? Is there screening that somebody does, or you're doing the screening? This is going to look different in everybody's facility. So that's why we really have to be general here. But it's a really good idea to sit with your team and your supervisor and let them know, what's my role? I know I'm going to get patients with dual diagnosis, and make sure that you have a referral for patients with dual diagnosis, right? Very, very important is you can't offer services if you don't have a place that's going to take both. So again, and always, always seek guidance from the healthcare team. You are not alone. Okay, there is a whole team to help you. So really want to make sure. Next slide. Next, we're going to jump to understanding suicide and SUD. And I wanted to bring up these demographics because who is, we saw those overdose and suicide rates, and we want to make sure that we know what's coming through our door. Gender, 78% of males. This is California specific demographics. 78% of suicides are 78% male, 21% female. Then the demographics goes to race and ethnicity. For 2019 and 2020, actually from 2019, it was 63.9 for white, 61 for 2020. So a slight decrease in 2020. The rate is 16% per 100,000. So that's also what we really want to make sure is this rate over here in the last box. So 16% white, 9.4 black, Hispanic 5.9, and look at the second, Native American 9.8. Even though their numbers are small, less than 0.5 and 0.4, the rate of per 100,000 is 9.8. They come in second. So definitely want to make sure that you're aware. And also Asian Pacific Islanders, that is the only race ethnicity that has increased from 2019 to 2020. So again, this is from California demographics, California Department of Health. So if you would like to see that, you can go to their website. Okay, and I think Chaya put it in the chat. So again, we just want to make sure you're aware of who's actually committing suicide deaths. Okay, next slide. Supporting patients with suicidal ideation. We want to make sure that you know SUD is a risk factor for suicidal attempts and completions. They're paired together, so we always want to make sure that you guys are aware of that. Patients may feel frustrated and hopeless. They always seek guidance from healthcare team when a patient exhibits warning signs, okay? And consider screening patients post-overdose for suicidality. Not all overdoses are accidental, okay? And really build that trusting relationship. I would really, really stress that, because with all of this, it's that hope, regardless of whether their suicide or substance use disorder is making them have those suicidal thoughts. This is building a trusting relationship. What other things do you guys do to support your patients that are having suicidal ideation, or they may really feel that they want to die if they're not doing, their drug of choice? What is it that you guys are telling? Let us know in the chat. What are some of the supporting strategies that you guys use that you can help? Because I know you guys are doing a lot of this work, right? Definitely. Okay, what are some other signs? Just patients feeling empty, right? And they're hopeless, they're trapped. We've already talked about that. They're anxious, they're full of rage, and just the unbearable emotional pain. And then we want to make sure that you always watch out for behaviors, right? Such as they're talking about dying, planning ways. They tell you, I'm going to go, jump off the freeway off ramp. There's always some, and you really need to investigate and talk to them and let them know what's going on. Also, um, they're taking dangerous risks, right? That's really, here we go. We've got some supporting strategies, but they're taking risks, and if they're doing that, again, just listening. You're right, Nicole. Listening is key. Often, just times talking and trying to help them resolve. Honestly, giving them a platform to talk to, because everybody in the emergency room is busy, right? We know this. Everybody's going somewhere and doing the next thing, and it's nobody's fault. And one thing that the Navigator has is the sake of time. And I love this, that you guys are listening. And that is one thing you guys definitely can offer, is listen to the patient. So I think we have our best practice here, right? You guys definitely talk, talk. Um, yeah, expand and tell me more. That was from our Navigator update. We had Yvonne tell us, that's just tell me more. And I love that. All right, next slide. Now, I just wanted briefly to talk about behavioral health screening tools, because there are some. Most hospitals and organizations that are Joint Commission have to do a suicide screening tool or severity rating scale. If you do not know these, it's okay. You don't have to know. But I only mention these because I want you to know, if you are looking through the chart and asking, trying to find out if this patient is truly suicidal, there is a screen. And usually a suicide screen is a simple yes or no question to identify the need for further evaluation. Some organizations, these are the most common, is the Columbia Suicide Severity Rating Scale. It identifies if someone is at risk. And then there's the Suicide Assessment 5-step evaluation and triage, and its abbreviation is safety. And right here, it just shows I identify risk, conducts an inquiry, and determines the level. So, we're going to go into legal holds, and this determines the level that's appropriate for the intervention. So again, your social worker team, usually it's the nursing team, are doing these screening tools. Okay, next slide. Warning signs of suicide. We already talked about that. Go ahead and next slide. I think it got out of order. This is an example of the suicide screening tool. And I just, again, wanted to show you that this is directly from SAMHSA. So if you wanted to follow up, if you look that up, and again, if you notice on SAMHSA, 988 Suicide and Crisis Lifeline is there as well. So that just, I loved that picture. So wanted to share that with you. Okay, next slide. So we've already talked about best practices. You guys have them all in the chat, but just a quick review: know your hospital's processes, provide a safe environment, refer to your social worker and nurse for guidance, provide resources. And if there's anything you learn from today, know that National Suicide Prevention Line has changed to 988. And again, we'll put the link for your partner toolkit. Definitely, we will put that in the chat again, because you can start a campaign and just reminding everybody. Most of, if you've done any type of advertising, that's one thing that we always asked you to include, is the 1-800 number. So again, Chaya put that in the chat. Provide a follow-up call. Some of our patients, I know you do that for SUD, but if you also, have time to do that, just to let them know you care, and always provide hope. And that's what you guys are doing. So I'm so relieved that you guys know these best practices already. Like I said, they're kind of similar, you guys. So you're already doing what's expected. And again, it's just adding that dual diagnosis and making sure we have the right referrals for the patient. Next slide is going to be Latoya Mitchell. You guys know her from Navigator Update and from all things onboarding, our onboarding specialist. Latoya, I'm going to give it to you for legal holds.
Awesome. Thank you, Sherry. Okay, so before we get into legal holds, I do have a poll question. So if you will take a moment to fill out this poll really quick or answer the poll. What is the designation for your hospital? Are you a general acute care? Is it a psychiatric hospital? Or maybe you're unsure? Let us know. And while we're waiting on those results, I hope that everybody is having a wonderful day. All right. So from the poll results, looks like, wow, an astonishing 91% of your sites are general acute care. 2% is a psychiatric hospital. And then a few of you, about 8%, maybe aren't sure. And that's perfectly fine, but it also is, as I suspected, majority of our sites are general acute care. If we can go on to the next slide. I wanted to ask that question because how each site kind of interacts and deals with holds can vary depending on what your site designation is. And I also wanted to make sure that the descriptions I'm giving you for these types of hold are cut and dry, as accurate as possible. They are not my opinion. They come directly from the Welfare and Institutions Code. So most of your sites are non-psychiatric hospitals. So you might be more familiar with 1799, even though they might still be called a 5150 hold or even just a psychiatric hold. But a 1799 makes it where if a person meets criteria, then there can be a hold placed by emergency medical care providers in the general acute care hospital setting for a period of up to 24 hours. Typically also in that time frame, there might be some sort of referral or even screening to mental health association. So here in Bakersfield, a lot of times we have what's called a MET team that will do a psychiatric screening for our patients that are placed on a 1799 hold. And then the other hold is the 5150, which is very well commonly known, but this is where it's a 72-hour hold for a person that meets criteria. And this is normally in a psychiatric setting. But again, it might be something that you hear even in your, general acute care hospital. So the criteria that I've mentioned already a few times that has to be met before placing somebody on a hold is also listed on this slide. So that criteria is either 1, they are a danger to themselves. 2, they are a danger to others. Or 3, they're so gravely disabled and or unable to care for themselves, they can actually be placed on a psychiatric hold. Those criteria don't have to, you don't have to meet all 3 criteria at once for a hold. It could be one of any of the 3. It could even be 2 of the 3 or possibly all 3. But just one of the criteria has to be met for a medical professional to place this person on a psychiatric hold. And so the last little bit that I wanted to mention, as we've already talked about so far, is just recognizing your role as a as a navigator with these types of holds. Remember to talk with your team, talk with the nurse and ask, is this patient, available to speak to me? Can I go in there? Is it safe? Has the hold been lifted? Is this patient also in withdrawals on top of their psychiatric hold? How can I be of assistance? So establishing that team workflow and really understanding how to work together to help these patients is going to be really key. And that's all I have.
Thank you very much, LaToya. So I hope that really made some sense and clarified, because I know sometimes if you're new to the emergency room, you might not know those terms. So here, always remember, this is a safe place, okay? I want to make sure, responding to crisis, the AB 508, I want to make sure, we're going to do a poll, and it's going to come up in a second. Do you complete the AB 508 yearly training requirement? Yes, no, I don't know. We want to make sure that you are in the emergency room, and this is required training from Title 22 with that health and welfare and safety code that LaToya mentioned. So want to make sure that you are aware of the education requirement of working in the emergency room. This was a law because we need to know how the stages of crisis and de-escalate. And in the emergency room, I am sure you've seen many patients become violent, and we just want to make sure that you guys know the correct training. This is not an AB 508. We have a short amount of time, and for the sake of time, we're just going to see where we are with stages of crisis, de-escalation. All right. Thanks, Destiny, for letting me know. Okay. Oh, we have a CPI instructor. All right, in the house. Okay. All right. So 32% have yes, they've made. Definitely great. No. Okay. So definitely in working in the emergency room, I suggest you speak with your supervisor. This is a law. So you must have that mandatory training. It is usually provided by whoever is doing the emergency training in your hospital. It's kind of just like your basic life BLS card, your heart CPR card. It's a renewal every year. So if you do not know, please, you can actually reach out to me. This is not a course in AB 508. It's something that you will need to do outside of this, but please, my number is, my email is scisneros@cabridge.org, and we'll put that in the chat. This course is also called STAMP, is a technique that is used in de-escalation. It is not the class. It's for assaultive management of assaultive behavior class. That's what the assaultive behavior 508, AB 508 is. It's management of assaultive behavior. MAB, it could also, yes, MAB course. So those are some of the abbreviations. And again, please reach out for those that do not know. Just ask your supervisor. And if you need more information, we are here to help. At Dignity, thank you, LaToya. You guys are great. You're helping me out. It is also called AVADE. I don't know that. Do you know what that stands for, LaToya? If you want to jump on here.
Not at the top of my head.
Okay. Yeah, I don't know that. Maybe Gabrielle, do you know what AVADE? So that way they can ask. I don't know what that.
We'll figure it out. We'll put it in the chat.
Okay. Okay. Thank you. Put in the chat. And CPI is in Louisiana. So that's great. It's crisis prevention intervention training, right? So, it's in different things. It's, depending on where you're at. but it is AB 508 is the law. CPI for Loma Linda. Okay, so we're getting lots of information and clarification. And again, STAMP is a acronym for responding to aggression. That's, if a patient's staring and eye contact, their tone and volume of voice, their anxiety, their mumbling, and their pacing. So again, these are techniques and that will be in the toolkit. For sake of time, I'm going to go past this. And again, if you need more, oh, here it is: awareness, vigilance, avoidance, defense, escape. Applying trauma-informed care. We do have a wonderful video on trauma-informed care for navigators. So we are going to mention it. The next slide I want to put up. I think what navigators need to know specifically is resist triggering the patient. We do not want to re-traumatize them. This is, the ED is not a place to get their story, right? Because it will be triggering. It might be being in a chaotic environment, having people with security outfits on. It might be males for females, right? And vice versa. There's lots of trauma. So again, as a navigator, we want to make sure that you're aware not to trigger the patient. That brings up, more harm. Understand trauma and how it affects groups and individuals. Recognize the sign. If they're not really wanting to engage, letting them lead the pace of your conversation, and respond to trauma. If they're actively having it, let them know they are in a safe place. Next slide. Now, again, I'm so sorry, we're trying to hurry, and we have some wonderful case studies. We have our behavioral health navigator panel. We are going to start with the Sutter team of Jody Norrell and Sue Hansen. And we are going to start with case 1. And I'm going to read the case study, and Sue and Jody, if you want to, just correct me or answer. So this patient was a 30-year-old patient with suicidal ideation, alcohol use disorder, and methamphetamine use, admitted to the ED on a 5150 hold. The navigator provided alcohol and other drugs, an assessment for treatment wait list. They discharged the patient to a faith-based inpatient treatment, but did not stay. Did I get that right, you guys?
Yes.
Okay, and then over the next month, they presented at several EDs. So this sounds like a patient of mine, okay? I'm gonna say, guys, right? We've had this patient. I think we've all had this in our necks of the woods. And then this patient came back to you after these months of going all over. Yeah, everybody knows this patient, you guys. So what is it that you guys did? Come on. And there's no right answer. We're sharing this because this is really shows a complexity of a patient that needs a whole healthcare team. You guys take it away.
So this gentleman, like you said, kept returning to the ED for suicide ideation and alcohol and drug issues. He actually had a traumatic event that occurred to him. His wife passed away. And he was, again, placed on a 5150 hold, went to a psychiatric hospital. I coordinated with him, the psychiatric hospital, and the county AOD office, where we were all three able to assist this gentleman in getting into crisis residential for 30 days, and then into a drug treatment program for 90 days. And then from there, he ended up in a follow-up transitional living that we have here in Sacramento, and he is doing very well. He is getting mental health care as we speak, and doing very well. One of the things that I often do is I do a lot of follow-up. I have kept in contact with this gentleman from day one, and he was probably one of my very earliest patients that I ever had. So I've been following up with this gentleman, and he has been following up with me for over a year now. So
That's amazing, you guys. And, you know, we're sharing this because it takes a team.
Mhm.
Definitely, because your role, Sue, is probably with the inpatient psych, that was more the social worker, but you continue to follow him. That's something not a lot of navigators do. So just want to hear that aspect from you. What is it that, you know, is it because that relationship with the social worker that you know, you can kind of develop that team approach? Because that's really amazing that you followed him after the inpatient psych 30 days, right? That was correct?
Oh yeah. Yeah, I
So,
followed him after he actually went through 2 Christian treatment facilities and didn't stay. I followed him through all that, followed him through the inpatient psychiatric hospital, the crisis residential, and I still follow him actually. Not too
that's
often, but we talk.
that is going above and beyond. And Jody, as the supervisor, you know, was this hard for you to grasp, or you're on board? Because I'm trying to let other navigators know, because this, you know, did you consider this out of her scope? Because she's still following up, you know, the 30 days, the 90 days. Can you tell me, as a supervisor, you know, hearing these stories, you're the one that brought it to me, so I know you're very proactive, but let me know your perspective.
Yeah, I think, you know, definitely not out of her scope. I think we have a handful of our Sutter sons, I believe, that are on this, and we definitely, one of the many tremendous values that the sons bring is this attention that they can provide, not only in the moment of crisis in the ED, but that follow up afterwards, because we know that that's not happening. If that was happening, we likely wouldn't have seen them in an acute crisis. So Sue and all of our sons do an amazing job of following up with the patients. And Sue is at one of our highest volume EDs, and the fact that she's still able to do this extensively and longitudinally is amazing. I think for me as the supervisor, and because I cross like some of the other supervisors, multiple counties, the things that struck me in this is the multiple delivery systems that Sue and the patient had to go through. You have the, you know, the county mental health department, which is one. You have the county ODS department, substance use department is another. You have a community-based, faith-based inpatient treatment facilities, and all of these step-down levels of care that are not integrated. Because if they were, that patient could have immediately been able to be sent to an inpatient facility that was co-occurring or provided dual diagnosis treatment, and wouldn't have had to be bouncing around to all these different delivery systems that were struggling to meet his needs. I'm also struck by the fact that, you know, Sue has insight because of our electronic health record. You also have visibility into the system utilization, so you can see the multiple hospitalization events and occurrences, and that she was actually able to, you know, get in there and see that and attune to that. Sometimes when you're doing ED work, you can't always see all of that system utilization. That's really helpful when you're getting a comprehensive picture for patients. And then taking these scenarios, which all of our sons have, like we said, very similar, you know, patient profiles, and taking these and elevating these conversations to our county leadership. This is what they need to hear, to, especially right now, why they're, you know, in this midst of major transformation under CalAIM and things, and they need to take these types of case studies and begin to recreate a system that doesn't mirror what this individual and this son but Sue had to go through in order to get care. So I feel like as supervisors, and at least in my role with all the counties where we have sons, this is taking these experiences and elevating them for systems level change is our responsibility.
Well, I really thank you for sharing this. And this is really an eye-opening, because it tells you how much we can get involved and make a difference for this patient. Sue, that's amazing work. I am so beyond impressed by you following this up, because as a navigator, sometimes I'm not gonna lie, you guys, after 30 days, it's like, okay, if they don't call, I'm not gonna, call them back. So I really commend the Sutter team on working on building those relationships and even going back 90 days and making sure that that patient is in care. Thank you so much, you guys. I really appreciate that. Our case 2, we're running down on time, but I did want to get in there. Case study 2 is from our Martin Luther King team, Gabrielle Hudson and Elizabeth Velasquez. And I just wanted to share, this is our last case study, is our 41-year-old male who was brought in by ambulance due to altered mental status, was found face down unconscious in the street covered in feces. And we put that because how many times I had this patient too, right? Come on, guys, in the chat, tell us. We know this patient also. Patient was evaluated, underwent a urine drug screen, positive for amphetamines. He stated he started amphetamines after the death of his father. Again, there's a traumatic experience. He was irritable, difficult conversation, and the patient was admitted for the further workup. Can you elaborate on this patient, you guys?
Yeah, thanks so much. So this patient, Elizabeth and myself worked on together when he was admitted to the inpatient floor. So we were working with him, we call it upstairs, but on the inpatient side. He had very high blood sugar levels and unmanaged diabetes. So his numbers were crazy. So he had a lot of health issues going on, as well as other chronic health issues on top of the diabetes. So Elizabeth was consulted for the positive urine screen. Do you want to talk a little bit about your assessment with him?
Yeah, I went in to see the patient, and he was interested actually in treatment. Actually, I introduced myself, and I told him I was there to give him the best service that we give our patients as they're returned to the hospital. He did mention that he was using meth, and he wanted to stop. The reason he was using it was because his father had passed away in August of 2021. He was a caregiver to his father, and he just lost it. He said, I just lost it. I pretty much, end up in the street using it every day. He said he actually spent like close to $100 a day. So that was a lot of meth that he was using. He also was addressing, he was diagnosed with bipolar and schizophrenia as well. He was actually taking medication, but because of the substance use, he stopped using it because he knew that it was going to be danger to his, to his health due to he had a lot of health problems. We ended up doing the referral to Tarzana. During the assessment, he was a little bit aggressive. He was not really comprehending a lot of the questions that they were asking him due to, he said he was a little bit slow, and it was overwhelming to him. After that, they did mention that it was probably going to be, hard for him to enter into a treatment place, but they finished the treatment. We were going back and forth working with the patient, and like Gabrielle was saying, he also needed mental health. So
Yeah.
the medication was
Yeah, so then
well.
I was called onto the case as well. I'm a behavioral health specialist is my title, but I work a lot with Elizabeth and Steve, our sons. So I was called on due to the history of schizophrenia and bipolar. So immediately we got the psychiatrist involved so we can restart him on his psych meds, because we know with residential treatment programs, they want them to be stabilized psychiatrically or mental health wise before they get into treatment. And I was also consulted because of his behavioral concerns. He was very irritable towards staff. He was kind of trying to sneak food from the medical staff, and because of that, his blood sugars were totally unmanaged. So I was able to sit down with the patient and the doctor, as well as the bedside nurse, and we talked with this patient for about an hour. The doctor explained diabetes, how to manage the blood sugars, why he has eating restrictions, because the patient was mad. He felt like he was being treated like a child because he couldn't eat. And just the danger with unmanaged diabetes. And then we also kind of talked to the patient in detail about the requirements if he were to go to residential treatment program, that he would need to participate in the groups, and he wouldn't be able to you know, yell at the staff there at the residential treatment program. And he would also, you know, need to have his diabetes and blood sugar under control. So we spent a long time with him, and he was, you know, very, very tearful. He did have a lot going on in his life. But I guess we wanted to turn it back on you guys, or if you wanted to add anything, like what other ideas would you have for this case? Because he was a really tough one.
Well, at the end, he ended up leaving AMA because he was not pretty much, you know, following the instructions from the doctor, and the doctor was a little bit upset because he already knew that the high blood pressure was not being under control, you know.
Yeah.
Yeah, you know, and again, there's no right or wrong to these case studies. And I said, Gabrielle was asking me, you know, what kind, and when she said this, what do you guys think? I know we only have one more minute. If you have to leave, we totally understand. But you know, this is reality. This is our navigator. This is our healthcare. This is ED reality of a patient leaving AMA. Anything else that you guys can think of and help us with these situations? Because we know, Gabrielle, and this is not just you guys only.
Yeah.
This is all through California. We know this patient, right?
That's correct.
They all come through. We collaborate. Keeping with discharge PT is a little easier. Yeah, we could definitely. And again, if you have any suggestions, anything else, set them up with harm reduction. Great answer. Just never give up. Yeah, never give up. Offer hope. You know, and it might not be the first time. That's the first time he came. It might be the second, the third. I've had a person a whole year coming in and out, right? A whole year. And finally, I'm ready for this. And meeting them where they're at. So definitely, you know, harm reduction on a great approach. I thank you guys. I'm going to cut it short right now. I thank you for our panel, our setter team and our MLK team. You know, we could go on, and we may have a part 2 because this is so great and so much interaction, you guys. Just last final things, if you want to advance the slide. Just remember, diction is not a moral failing. That's our standard slide. Next slide. Our resources, we always want to make sure, if you want to get on, use our QR code. I'm going to leave it there for a minute, as well as it's in the chat for our website. Next slide. And then if you don't know substance use only medical, always remember that it's also a crime just to use illicit drugs. Next slide. I want to go to our mentor slide. We're on Facebook and Twitter and Instagram, but our mentor team, if you do not know who your mentor is, ask us, okay? mentors@cabridge.org. Very important for you to know. They can get you connected with other mentors. They can get you, we're starting county. Jody did mention county services. We, again, are just starting our county pods, and that's really to get other mentors or other navigators with our mentor and connect and get resources for your own specific county. So if you're being invited, again, we just want to network. It takes a team, you guys, and sometimes county resources are not available. So just sharing resources is always wonderful. So I encourage you, reach out to us. If you don't know who your mentor is, I am Sherry Cisneros. I am the Navigator Program Director. We thank you. Sorry for going over. And again, make sure you're on Slack. We really encourage our Slack channel. If you're not invited to Slack, please let us know. And we, again, you have our contact information. Thank you. You've been wonderful. We wish it could have been more time. And we appreciate and hope to see you in LA, right? November 1st. Any questions before we leave? You can put them on Slack and we will answer later. So don't feel that we're shutting you off. If you have anything, again, please put it on Slack and we can answer those questions anytime. So please, again, put it on Slack. If you're not part of Slack, please reach out to us. Thank you and have a great day, you guys. Bye.
Thank you.
Bye.
Bye.
Bye.